From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Welcome to our listeners from around the world for this JAMA Clinical Review podcast. I am your host, Mary McDermott, Deputy Editor of JAMA, and I'm here today with Dr. Nimish Vakil, who is Clinical Professor at the University of Wisconsin School of Medicine and Public Health, and we'll be talking today about his JAMA review on peptic ulcer disease. Welcome, Dr. Vakil.
Thank you very much for having me.
Your review talks about the fact that peptic ulcer disease affects about 1% of the population and mentions that about 54,000 people each year are admitted to the hospital for peptic ulcers. You also note that approximately 10% of people who present with upper abdominal pain in a primary care practice have peptic ulcer as a cause of their symptoms. So maybe we could start with what are the typical presenting features of peptic ulcer and what signs and symptoms should the generalist physician consider when a patient presents with abdominal symptoms to decide if this could be peptic ulcer?
So the typical symptoms are pain and discomfort in the upper abdomen. Unfortunately, these symptoms are rather nonspecific, and they also occur in other conditions, notably in a condition called functional dyspepsia, where there are no abnormalities at the time of endoscopy. Other presenting symptoms overlap with other conditions, so you can have patients presenting with heartburn, with symptoms of acid indigestion. So the symptoms are rather varied, and the unifying aspect of the symptoms is that they're localized to the upper part of the abdomen. And with regard to physical signs, the only physical sign in uncomplicated peptic ulcer disease is epigastric tenderness. But again, that's not specific, and that can occur in reflux disease as well.
And what risk factors do you ask about when you're considering that possible diagnosis?
So the main risk factors are use of non-steroidal anti-inflammatory drugs or aspirin, so I always inquire about that. It's also important to evaluate where the patient grew up and whether the symptoms have been long-standing, because the other main cause of ulcer disease is H. pylori infection. This tends to be more common in people who've come from other countries than people who were born here. It also tends to be more common in people who are older than 60 years of age, because H. pylori was very common in our country back in the 1930s and 40s, but its prevalence has been declining. So young people born in this country in the 1990s and 2000s are less likely to have H. pylori infection than people born in the 1930s and 40s and 50s.
I wonder if we can talk a little bit more about H. pylori. Specifically, among people with H. pylori, what proportion will develop peptic ulcers? And then also among people with peptic ulcer, about how many have H. pylori?
So if we look at the situation from the causation standpoint, if you look at a broad cross-section of people with peptic ulcer disease, a significant proportion of them will have H. pylori infection as the cause. And this can range from 70% and in some countries up to 90%, because most of the population is infected and the major cause of ulcer disease is H. pylori infection. On the other hand, if you look at patients who are infected or populations that are infected, the lifetime prevalence of ulcer disease is about 10%. So not everybody with H. pylori infection will get an ulcer. Some people will live and die with that infection without really developing any problems with it.
So when do you test for H. pylori?
So I think the first principle of testing is that you should test for H. pylori when you intend to treat H. pylori infection. So you've got to have symptoms that you attribute or think are likely to be caused by H. pylori infection. If I have patients who present with upper abdominal pain that's consistent with gastric inflammation or peptic ulcer disease, I would think that that is an indication to test for H. pylori, because there are good data to show that in this situation, treating the H. pylori infection will resolve the symptoms in a substantial number of patients.
And then can you just take us a little further? If you have a patient in your office and you think these symptoms seem like they could be peptic ulcer, you would test for H. pylori. What else would you do? And when should a generalist decide to send someone for endoscopy?
The next set of questions I would ask the patient would be, have you noticed black colored stool? Have you had weight loss? Have you had other symptoms that would point me in a direction where I would be concerned about a more serious underlying condition? Now, if the answer to all these questions is no, and the patient is younger than 65, according to some guidelines, 60 according to some, then a sort of non-invasive strategy of testing for H. pylori. I do want to circle back to why the age question is important. New symptoms developing in individuals older than 60 years of age can be a sign of malignancy in the upper GI tract, which can masquerade as peptic ulcer disease. So we would not want to miss that while spending time doing diagnostic testing for H. pylori and testing out the treatment and seeing whether the patient improves. In younger patients, gastric cancer is so rare that this is not a serious consideration. And so in these individuals, it's not only cost effective, but atraumatic for the patient to have a non-invasive test and do a trial of treatment with H. pylori and see if everything resolves.
And what is your favorite treatment today for H. pylori?
So in this country, we have a kind of a unique situation. We do have tests that will tell you about antimicrobial resistant strains of H. pylori. That's a really important problem worldwide, with varying incidence of resistance, and that depends on the background use of antibiotics in the population. So in populations where clarithromycin is widely used for upper respiratory infections, we have highly resistant strains of H. pylori which simply don't respond to clarithromycin-based treatment regimens. We do have tests such as culture, and we have molecular tests that can test for resistance of H. pylori, but they're typically not covered by insurance. They tend to be expensive, difficult to obtain. So the average primary care provider has to use a regimen that generally is very effective regardless of prevalence rates of H. pylori resistance. And so my favorite regimen, also because of its relatively low cost, is quadruple therapy. And quadruple therapy consists of a proton pump inhibitor taken twice a day, along with bismuth, metronidazole, and tetracycline. And these three agents are antimicrobial to H. pylori. They work in synergy, and the treatment duration is 14 days.
Do you have a favorite proton pump inhibitor that you use?
There are some data to suggest that the use of esomeprazole and rabeprazole are associated with better results in H. pylori eradication. But the evidence is not strong enough for us to say that we should only use those agents and not use the others, because the others are also successful in this treatment regimen.
And then after the 14 days of H. pylori treatment, do you continue the PPI, and for how long?
So you can go in one of two ways. It is not necessary to continue the PPI beyond the 14-day time point. Some practitioners continue for a week or two just to provide additional relief for the patient. My own preference is to treat the patient for H. pylori for 2 weeks, then stop all the medications, wait for a month, and then test the patient to see if H. pylori has been successfully eradicated, and at that point assess their symptoms as well.
And can we talk a bit about the testing? You have this nice table in your review that summarizes which test should be used when. So for the generalist physician, what is the first test they should reach for?
To diagnose an H. pylori infection, I think this bears some explanation. So remember that we said that the infection is typically acquired in childhood, and you do develop antibodies to H. pylori which circulate in your bloodstream. The trouble is that since H. pylori lives offshore in the gastric mucus, these antibodies are not very effective in eradicating H. pylori. And the antibodies persist in your bloodstream even when H. pylori is eradicated. So you can imagine that as the prevalence of H. pylori in a population goes down, the serologic test becomes inaccurate because so many people have had H. pylori eradicated, but the serologic test is positive. So in the past, we used to recommend serology as a low-cost test, but now the false positives, that means the patients test positive for serology, but if you do an actual test for active infection, so many people are negative that serology is not reliable as a test to base a treatment decision on. The main role of serology is to rule out an infection. Since so many people are positive with serology because of the anamnestic reaction, a negative test, however, is quite useful because if the patient is negative with serology, it's very unlikely that the patient has H. pylori infection. So, taking the scenario which we talked about, where somebody presents with upper abdominal pain and you're trying to make a decision whether this is H. pylori and you want to treat it, the two tests that we would recommend are the breath test and the stool antigen test.
And are those equivalent? Either one is just as good, or what considerations are there?
Yes, they're really equivalent in terms of their accuracy. So there's 1 or 2 percentage point difference, but for practical purposes, there's no difference between them. They can both be ordered through national laboratory chains in the United States. And the main advantage of the stool test, aside of the messiness of collecting stool, is that you can collect it at home and mail it to a central laboratory, so you don't have to go anywhere to do anything. You can do the same with the breath test. The breath can be collected in a bag that can be shipped to a laboratory, and you can do the test at home.
So let's say you think a patient has peptic ulcer disease, their H. pylori testing is negative. What therapy would you choose in that case?
Now, there are two pathways you can go down. You can do a empiric trial of acid inhibition with a proton pump inhibitor using a low-cost, over-the-counter proton pump inhibitor in the United States, for example, or by prescription in other countries. And you do a trial of a proton pump inhibitor for 4 weeks. Now, here the presumption is if this is an H. pylori negative ulcer, for example, the ulcer will heal and the symptoms will disappear. And in this case, there's no requirement for further intervention if the patient becomes asymptomatic. Again, this is driven by cost effectiveness principles, practical principles of avoiding invasive testing in patients unless absolutely necessary.
And if someone does not respond to that therapy?
Then that is a time for endoscopy. At this point, we're recommending endoscopy primarily to rule out something more sinister, although we acknowledge that there is a high likelihood of finding nothing at endoscopy because numerically functional dyspepsia, which is a condition defined as pain or discomfort in the upper abdomen with no abnormalities at endoscopy or on diagnostic testing, is one of the most common conditions affecting the abdomen, just like irritable bowel syndrome is one of the most common conditions affecting the abdomen. So it's part of the spectrum of functional GI disorders. So the clinician needs to understand that we are starting with the treatable conditions first. Then we are moving from H. pylori and acid-related ulcer disease to ruling out rarer, more sinister conditions. And then we acknowledge that we may be left with no firm diagnosis and no findings, and that diagnosis may be functional dyspepsia.
Can you talk about the role of diet in the development and treatment? Are there any foods that can cause or help eliminate a peptic ulcer?
Yes, this is an interesting question because we used to believe that diet played a very significant role, and there were some very interesting historical references, which I think it's worthy of acknowledging, that at one time we used to admit patients with severe ulcer disease to the hospital and feed them diets which were high in animal fat. That means they were cream and whole milk and so on and so forth. And we thought that these would neutralize the acid in the stomach. And they did, but the high protein content of these meals further stimulated acid production. And paradoxically, we made the patients worse in some of these circumstances. The role of diet has become much less important today in terms of causation because we now know what the principal cause is. So we know, for example, that spicy food doesn't cause ulcers. We know that coffee intake doesn't cause ulcers. We used to think all those things were responsible for ulcers until we discovered H. pylori. But diet does plays a role in aggravating symptoms, so that very spicy food, if you have an ulcer, will certainly aggravate your symptoms. Food which is very high in protein will stimulate acid production and potentially aggravate your symptoms. So it has an indirect effect, but no longer considered to be a causal effect in ulcer disease.
What is the role of stress in the development and resolution?
Yes, stress is an important factor, and I think interest in stress is re-emerging. So there are two lines that we can look at. People who went to medical school 40 or 50 years ago, we were presented with a prototype of a duodenal ulcer who was the highly stressed executive who ate irregular meals. That was a classic prototype of duodenal ulcer. Now, after H. pylori, this has all gone away, and stress has now begun to reemerge. So, what are the lines of evidence that we have for stress? The first line of evidence is natural disasters. And so, a classic example is the 9/11 disaster and the Japanese tsunami. So, in the year following the Japanese tsunami, there was a rise in the incidence of idiopathic, that means not H. pylori, not NSAID-related ulcers in Japan in the year following that episode. Similar data have been presented for New York City, where after the 9/11 attacks, there was a rise in non-H. pylori, non-NSAID-related ulcer disease. So these are thought to be stress-related mechanisms for ulcer disease, and stress can drive acid production because acid production is part of the fight and flight response. So acid production can be increased under these circumstances. The exact mechanism, however, still remains unknown because we don't know why that effect should persist at 1 year.
And then let's talk a little bit about nonsteroidal anti-inflammatory drugs. Your review comments how within 7 days after starting one of these drugs, the risk is particularly high for peptic ulcer disease. Can you just tell us how you think about it when you're taking a history of nonsteroidals and how you might mitigate against nonsteroidal induced peptic ulcers?
So the first thing I'd say is that there are three types of ulcers related to nonsteroidals, and the literature mixes them up sometimes. So it's important to recognize that there are studies done with routine endoscopy in somebody taking NSAIDs. You may find an ulcer and the ulcer may be asymptomatic. Then there are symptom-based studies that look at patients who develop upper abdominal symptoms, have endoscopy, and are found to have an ulcer after starting nonsteroidal anti-inflammatory drugs. And then there are finally complicated ulcer studies which look at people with bleeding. Across the spectrum, you can find endoscopic ulcers without symptoms within a week. If you look at patients who present with symptoms, many of them will have started NSAIDs within the preceding week. And if you look at patients presenting to the hospital with complications such as bleeding from ulcers, a significantly higher proportion of them will have started NSAIDs in the week leading up to the bleeding episode. So all these lines of evidence tell us that recent commencement of NSAID use is associated with all three types of ulcers. And so one of the things that I like to find out when the patient comes to my office is whether they've recently been taking nonsteroidal anti-inflammatory drugs. Now, it's very important to recognize that as a clinician, that many patients don't recognize that they're taking nonsteroidal anti-inflammatory drugs because they think of drugs as a medication. I'll give you some examples. So I've had young women who come to my office and they say, no, I'm not taking nonsteroidal anti-inflammatory drugs. And then I say, how about when you have your period? Do you take ibuprofen or do you take medications for your period? And then some of them will say, oh, well, yes, I do. And I say, well, how many do you take? And you'll be amazed at how many young women take 4, 5 ibuprofen 5 times a day for 2 or 3 days. And that's enough to give you an ulcer. But if you ask them, do you take nonsteroidal anti-inflammatory drugs? They say no, because they're not taking them regularly. And so you do have to dig a little bit to get the information. Similarly, patients with arthritis, they think nothing of taking over-the-counter ibuprofen, and they don't even think of that as a medication sometimes. So you do have to be a little persistent and try to ferret out that history, particularly in very young people and then older individuals with arthropathy. It's important to kind of dig a little bit.
Thank you so much. This was really an informative discussion about peptic ulcer disease. Do you have anything that you'd like to add?
Yes, I just wanted to point out that we're seeing a growing incidence of non-H. pylori, non-NSAID related ulcer disease, and it often occurs in young people. The mechanism remains unknown, but I want to point this out because some of these individuals have recurrent peptic ulcer disease. So they get it, and then you treat them, and they get it again and again. So you've got to be aware of this kind of small but growing group of individuals, often young, and some of them will require long-term acid inhibition because we don't have a curative therapy for them.
That's interesting. Do we know why this is happening?
No, we don't. I think one phenomenon is that as we decrease the known causes of peptic ulcer disease, the somewhat rarer causes start becoming more prevalent, obviously, because H. pylori is going down and H. pylori ulcers are going down. So we may have ignored these individuals in the past, but they're becoming more prevalent now, and I think it's important for us to be aware of them. We obviously need a lot more research to figure out why they're getting ulcers, but right now we just need to be aware of them so that we treat them appropriately.
Thank you for listening. This is Mary McDermott, Deputy Editor of JAMA. For more of our podcasts, please visit us at jamanetworkaudio.com. You can subscribe and listen wherever you get your podcasts. This episode was produced by Shelley Steffens at the JAMA Network.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.